Hi, this is Alicia Bright back for part 2 of gas exchange applied to COPD. In this presentation, we're going to talk more about the nursing care and the nursing thinking about how we take care of these folks. So when we're assessing the patient, it's important to evaluate for potential environmental or occupational irritants. Kaplan has a really good case study that focuses on a coal miner. This is kind of a classic example of COPD. Of course, there are other things that can trigger problems with COPD and other things that cause COPD that we discussed in the previous lecture. It's really important for people with COPD to have an influenza vaccine and a pneumococcal vaccine because they're very vulnerable to infections in their lungs. Of course, if we can convince somebody with COPD to stop smoking, that would be good. Also, just as a rule of thumb, and we'll talk about it a little bit more, we do use oxygen therapy for people with COPD, but we use it very carefully. We'll talk more about that in a minute. So oxygen therapy has to be very carefully titrated to avoid over-oxygenating somebody. Remember, people with COPD become accustomed to lower levels of oxygen because they're not exchanging gas between the alveolar sac, the inside of the alveoli, and the capillary bed that surrounds the alveoli. So they compensate, the body compensates by increasing the number of red blood cells in the body. However, the body can also compensate by simply changing over the stimulation that it relies on to tell us when to take a deep breath. So you and I, sitting here in this room, all the rooms that we're sitting in, we are triggered to take a deep breath when our CO2 level gets high enough. Not when we get hungry, but when we are hungry for oxygen. But when we develop too much CO2 in our bodies, this is the CO2 drive. For patients with chronic COPD, their CO2 levels start to increase and their body becomes accustomed to it. They're not accustomed to, nobody can totally be accustomed to lower oxygen levels. So they change over to a hypoxic drive, meaning that if their oxygen level gets low enough, that's when the body decides it's time to take a breath. So we don't want to over-oxygenate these people. They may be accustomed to tolerating oxygen saturations down around 92, 91, maybe 90%. I've even seen people who tolerate around 89% oxygenated. It's important not to over-oxygenate them because if their oxygen level, if they're used to having an oxygen saturation at 90% and their oxygen level is actually, we give them extra oxygen and boost it up to 98%, gosh, we're happy. We have 98% oxygenation on this person. The problem is their body isn't used to it. And it says, well, we're way above 90%. We don't really need to take a breath here, do we? So while they're 98% saturated, that's great. What they don't have is a way to blow off the CO2. The CO2 levels will continue to rise and they'll eventually smother from the CO2 even though they have enough oxygen. We can actually suppress the respiratory drive if we give too much oxygen. So that's why this is the population we need to be very careful about when administering oxygen. But we do give them oxygen because it's demonstrated that it improves survival. It improves their ability to move around, to exercise, if you will. But for a lot of these people, it's just activities of daily living. It improves their ability to think, and it improves sleep. So we do use oxygen, but we use it very carefully, and the doctor will usually leave an order for it. It's possible that they might do surgical removal of a bullae or part of the lung, an area that's been so damaged. What happens is if that area is really congested, it's hurting the circulation in the body, the blood circulation, as well as the movement of air. So they'll just remove it, and sometimes patients do a little better. Sometimes they'll do a lung transplant This is possible, particularly in people with younger people who've developed COPD related to other things than heredity or cigarette smoking. But this has been improved to, been demonstrated to enhance quality of life. Of course, it's difficult to do because we don't have that many lungs to go around. We count on respiratory therapy quite a bit to help us, and physical therapy. It helps us retrain the breathing, teaching pursed lip breathing, teaching them how to use the instruments and the medication. Well, the medications we teach them how to use, but the instruments to measure their breathing capacity, etc. Physical therapy is the professional group that we collaborate with, and physical therapy, the respiratory therapy for breathing things, physical therapy for movement and strength training, hopefully keeping them active despite the fact that it gets harder and harder to breathe. And then there's chest physical therapy. I've got pictures. I'll show you a picture of percussion, vibration, and postural drainage in a minute. So some nursing diagnoses that pertain to the patient with COPD include, these should be starting to be pretty obvious to you. Ineffective breathing pattern, ineffective airway clearance from sputum, for instance. Impaired gas exchange, got that. Imbalanced nutrition, less than body requirements. Whoa, what's going on there? So remember we talked about people losing weight because they're actually having difficulty eating. It takes a lot of energy to breathe and it takes energy to eat, and we prioritize breathing over eating. Of course, another diagnosis for these folks is risk for infection because, as we said, they've got weak lungs. They're at risk for becoming severely ill with pneumonia or influenza. Goals that would be appropriate would be to prevent disease progression, to have the patient be able to perform ADLs, to relieve symptoms, and to avoid complications from COPD. Some of what we do, we teach pursed-lipped breathing. This is a prolonged exhalation. So they'll go ahead and take a normal inspiration, kind of deep, and then blow it out really slowly. The metaphor to use is if you had a ping pong ball and you wanted to blow it slowly across the table instead of popping it out across the table. If you want to make sure it didn't roll off the other end, you would blow slow and long to just control it very well and let it blow out slowly. This allows the alveoli to collapse more and allows for a more complete exhalation. What this accomplishes is more space for inhalation. It's like when you clean out your closet, you get rid of all your old clothes. Well, you've got room in your closet for more clothes now. Same thing in your lungs. If you get rid of all the old air, you have more room to let in the new air. So that's what the prolonged expiration does. And we help people learn to modify their activities of daily living. They may need assistance with this in the later stages. We do want them to keep exercising, use it or lose it. But we need to provide for adequate rest periods. Take time outs. Sit down and just rest for a little while in between activities. Get up, take your shower, and then sit down and rest, use your oxygen, and then get up and fix your breakfast. We help people start to pace themselves like that. Nutritional therapy is considerable. We worry about malnutrition. These folks can't eat right. They have a lot of inflammation going on. They have an increased metabolic rate to try and keep up with the lack of oxygen. They may not feel like eating. These folks get a high-calorie, high-protein diet, and try not to feed them a lot at one time. They do a lot better with smaller snacks, 5 or 6 small meals a day instead of 3 big ones. They just won't eat that much. High-calorie, high-protein diet. So positioning, obviously, we can elevate the head of the bed to help them be more comfortable. The tripod position is where they're sitting. So it's a tripod has 3 bases, and typically it's somebody sitting at the table and leaning their weight onto the table with their elbows. That's the 3 points, the butt and the 2 elbows. And this supports the person to lean forward a little bit. It helps them to expand the chest a little better, to expand the diaphragm a little better. And some people actually sleep in this position when things are really bad. In fact, I remember my grandmother, when she was in her 70s, sitting there at the kitchen table in the morning, in the tripod position, sipping her coffee, and then she'd have a good big cough, productive cough. She had chronic bronchitis and emphysema, and she would have a big productive cough, and then she would take another hit of her cigarette and put it back in the ashtray right there on the kitchen table. Yep. We have folks like that. She was not on oxygen. When people do that on oxygen, we're particularly scared. But anyway, there's that tripod position. It's for people who are really having trouble breathing, and in fact, sometimes they'll even doze off and sleep in that position. It's more restful for them. Psychological considerations. So obviously these folks may feel a tremendous amount of guilt over having smoked for as many years as they did. We warn people that smoking can cause this problem, and all of a sudden they have developed this problem and they realize they're mortal, and now they feel really stupid, really guilty. They can get depressed, anxious, obviously. When you can't keep up with the rest of the world, you can get lonely because the rest of the world is moving on without you. And people can get real frustrated from increased dependence. As an aside, when you have a grumpy patient, often these folks are grumpy for a reason. They're sick, they're miserable, and sometimes they lash out. And it's not good that they do that. But, sometimes when you notice that someone's being very grumpy, just never take it personally. Never take it personally. Respond with compassion. And I don't know how many times I've had patients who snapped at me. And I just realized that they're not feeling well. They snap at me. They come back later on and they apologize because they lash out at us because we're here. But a lot of them are just they're decent people, and then they feel bad that they've snapped like that. Always be gracious with it. Always be gracious. Okay, sleep, extremely important and difficult. Medications that they're on, those bronchodilators, we'll talk about meds. Bronchodilators will keep them awake. They may have some coughing or postnasal drip. We get decongestants or nasal sprays or oxygen therapy. Explore ways to keep your patient comfortable and try and help them get a good night's sleep. It's very important, of course, for all of us, and for someone with lung problems, particularly important. Other outcomes would be that they maintain their normal body weight, that they have normal serum protein levels. That would be a direct reflection of the nutrition that they're able to take in, the amount of protein they're able to eat. We want them to be able to report feeling well rested after sleep, and we want to see an improvement in their sleep patterns. So let's remember that symptoms can be managed. COPD is a chronic situation that in which the patient will deteriorate. They may or may not die from COPD, from respiratory failure. Often a pneumonia will come in and set in, and then they die. Technically, they die of pneumonia. But there may be other problems too. They may have a heart attack, and that might be brought about by a hypoxic episode. Other things can kill them, but generally they're going to have COPD for the rest of their life, and we expect it to get worse. So a lot of times we talk about end-of-life issues with these folks. To intubate these folks, we will never get them extubated. So if they go on a ventilator, we may never get them off. They may be on it for the rest of their life, and that's a very uncomfortable way to go. You can't talk to your family when that happens. It's a very restrictive way to live. So we look at palliative care quite a bit. We talk about end-of-life issues. We involve hospice in having care for people with advanced COPD. Drug therapy for COPD includes bronchodilators because it relaxes the smooth muscle in the airway. It improves ventilation of the lungs, and it decreases dyspnea and increases their ability to breathe. We prefer to use inhalers for bronchodilators. There are some systemic bronchodilators, but they're hard on the heart because of that alpha, beta 1, beta 2 effect. If you remember that from pharmacology, review alpha, beta 1, beta 2, you'll find the side effects of these bronchodilators have to do with increased heart rate stimulation. So just briefly, the bronchodilators that we commonly use are beta 2 adrenergic agonists, anticholinergics, and methylxanthines. Long-acting cholinergics, we might give Spiriva, and we can use inhaled corticosteroid therapy. Topical steroids, inhaled steroids, work directly on the lungs, and very little of it is actually absorbed in the body. This is different from swallowing corticosteroids such as prednisone. They may do that also, but we try to avoid that as much as possible. Terrible side effects. So the stages of COPD, again, you don't have to memorize this for this class. I just want you to know that some people have very mild COPD. It is expected that it will progress to moderate, severe, and then very severe COPD. If the person lives that long, that's probably going to be how it goes. So just take a look at this to get a sense of the progression of the disease. So for the nursing diagnosis of ineffective breathing pattern, interventions would be to monitor vital signs and lab results, to assist the patient with ADLs as needed, to provide rest periods regularly, and to administer medications as ordered. And then we want to teach them pursed lip breathing, abdominal breathing, and relaxation techniques. So here are some interventions that are directly related to the ineffective breathing pattern diagnosis. Imbalanced nutrition is another one. Less than body requirements. If somebody's not eating enough, we're going to assess their nutritional status, monitor lab values, particularly serum proteins. We might do a calorie count. We might definitely document what their food intake is. We might get a dietitian involved and do some collaborative work with them. Again, small frequent feedings, proper positioning for meals. Make sure they're sitting in a position where they're sitting up and leaning forward. We don't want them choking, and we want them to be able to breathe easily while they're eating. We want to encourage them to eat whatever they want to eat. The folks with end-stage COPD, we're not worried about atherosclerosis with them. We just want to get calories in. So a high-fat diet is not a bad thing for these folks if they can digest it. Not something that they can't digest, obviously. Not greasy, heavy foods, but they might have more oils in their foods than people trying to lose weight would have. These folks aren't trying to lose weight. Also, mouth care prior to meals is important. If they've got a lot of secretions that they're coughing up, that's kind of nasty in the mouth, and you want to just do what you can to clean up their mouth a little bit, freshen them up, freshen the face, the mouth, the bedside a little bit, make the whole area a little fresher for them before you bring the food in, and that's going to help improve somebody's appetite. General rule of thumb: if you're going to feed somebody, freshen everything up first. So this is a couple of pictures here. On the left, we have pictures of positions for postural drainage. So if there are areas of the lung that are starting to develop fluid accumulation, people are having patients having trouble coughing sputum out of a particular area. Respiratory therapy actually is really, really good at this. They use the bed and they manipulate the patient's position so that the patient can relax and be supported in the position. But then, for instance, if you see about halfway down, they're going for the middle lobes. The person's head is lower than their torso. And the knees are higher than the torso. So they've kind of turned the person upside down, and that's to help the fluid actually drain from the lung into the bronchus to make it easier for the patient to cough out the secretions. So again, we're using gravity. Gravity's our friend. and we're using gravity to drain the secretions downhill. Now, not everybody's going to be able to tolerate having their head down like that, but some people will. The picture on the right is percussion. There's different ways to do this, and we actually have these machines. Respiratory therapy has these great machines that sort of vibrate the patient's chest, these great big pads that they'll put on the patient to vibrate their chest, and that just sort of jiggles the secretions loose and helps loosen it out so that the patient can cough it out. But the picture there is just using hands, and it's a cupped hand, so you're not slapping the patient with the full flat of the hand. You cup the hand gently so that sort of air is trapped between the palm and the patient's body. And this is just a way of gently using your hands to loosen up and percuss the chest. You might see respiratory therapy doing this. Respiratory therapy are the ones that are really good at this, although this is a technique that nurses can use to help a patient breathe better in the event that you don't have a respiratory therapist available. So, a little question for you. I used to put this on exams, but it gave my students fits, so I took it off the exams. But I do want to discuss it. I actually remember something very similar to this that gave me fits when I was a nursing student, so I share it with you. A nurse is caring for a cachectic patient with COPD. Remember, cachectic means emaciated, very thin, very undernourished. The nurse knows the teaching has been effective when the patient states, A, I should drink a lot of water with my meals. B, I should eat a diet high in fiber. C, I should eat mostly protein and vegetables. Or D, I can eat all the ice cream I want. All right, let's think about this. If you're taking a lot of water with meals, are you going to eat a lot of food? No, probably not. If you're all full of water, you're not going to get a lot of calories. This is a great way to lose weight. We don't want these patients losing weight. How about B? I should eat a diet high in fiber. Well, once again, are there any calories in fiber? Nope. So a diet high in fiber may help somebody avoid constipation, and it may help somebody else avoid colon cancer, or both. But it's not going to help somebody maintain their weight. C, I should eat mostly protein and vegetables. Well, we like the idea of eating protein. They need protein, definitely. Vegetables are good, but between protein and vegetables, there's not a lot of calories in that one. Although, it's a healthy diet. If you want to lose weight, I think it's a good way to go. So this is why this always gives students fits. If the patient says, I can eat all the ice cream I want, well, what do we know about atherosclerosis? What do we know about healthy eating? Does this fly in the face of everything we know? Sometimes life's just ironic. In this case, if the patient wants to eat ice cream, we're not going to argue with them. We're going to ask them what flavor, okay? These patients are not training to run a marathon. They're not trying for a lot of longevity. They're trying to maintain their body weight and get enough calories in them to have strength to continue to breathe. So, we might encourage peanut butter instead of ice cream. We might make them a high-protein smoothie that's got some extra oil in it. But, if they want to eat ice cream, you just ask them what flavor, and we're going to feed them. All right, I hope that helps clarify things with COPD, particularly the idea of titrating oxygen. For somebody with COPD, we do need to be careful. And again, the idea of feeding them high-calorie meals. Protein and high calories. Ice cream, okay. Those are some of the things you need to know to take care of patients with COPD, and I hope that's helpful. Thanks.